Hi, everybody. I'm Nicole Clement. I'm a program specialist here at the National Rural Health Resource Center. Thank you for joining us today. We're super excited to have this webinar to really launch this new resource. It's actually only been out for a month or so, Sustainable Rural EMS, Navigating Change. And with us today are the folks that helped get this guide together. We contracted with Safe Tech Solutions to get this guide together. And so Aaron Reinert and John Becknell from Safe Tech Solutions are going to talk about the guide today and really kind of go through the whole process of starting with helping a community figure out if they have an EMS problem and then how to move from there so that they can actually change that so that they don't have an EMS problem, moving towards more sustainable models. Also joining us, Marty Link, who is the Director of EMS and Trauma at the South Dakota Department of Health. I'm going to just read really quick bios as a way of introducing our speakers. So first, Aaron has become nationally known as a leader, master teacher, and expert in management, leadership, system design, and applied best practices in rural and small town emergency medical services systems. Aaron has been involved in EMS for more than 30 years and is the executive director of an EMS service in central Minnesota. Using tools such as Balance Scorecard, Aaron helps organizations recognize the necessary balance between finance, customer service, employee satisfaction, and community awareness. John is a community and organizational psychologist and an accomplished facilitator, interviewer, teacher, and researcher. He has been involved in emergency services and healthcare for 35 years and has worked as a paramedic, educator, manager, systems developer, and consultant. John is the founding publisher of Best Practices in Emergency Services and the former editor-in-chief of the Journal of EMS, or GEMS. John has been involved in emergency medical system development in North America, the Middle East, and Central America, and he is the author of 2 books and has published articles in numerous journals and trade magazines. And Marty, unfortunately, I don't have much of a bio for you. So when it's your turn, if you want to tell us a little bit about you, you go ahead and do that. But otherwise, for right now, I'm going to turn it over to Aaron and John.
Great. Thank you, Nicole. It's great to be with you. So Aaron and Marty and I simply want to have a conversation. We think that the best way that we can introduce this new resource guide is simply to talk a little bit about these issues and to talk with each other and share some knowledge as we present this new guide. So the topic, of course, is Sustainable Rural EMS. And Marty, I just want to turn to you and let you introduce yourself a little bit. We wanted Marty to be with us because Marty is the state EMS director for one of the most rural states in continental United States in the lower 48. And we've worked with him intensely for the last 10 years in working with rural EMS systems. So Marty, tell us a little bit about you and welcome.
Hey, John, thank you. So good afternoon, everybody. So it's a privilege to be here with these 2 esteemed individuals. Like John has said, we've been able to work together in partnership for well over 10 years. And we've seen some significant strides in South Dakota. So a little bit about my background. I'm paramedic. I've been working with state government in South Dakota for close to 20 years now. I think February will be my 20-year mark. So had the privilege of meeting all kinds of wonderful people across the state as we get out there and try to explore and identify what are some of their challenges, what are their successes. So that's been very beneficial for us, especially living in a small state. There's a lot of windshield time, but when you get out and you have candid conversations, that's when you really identify what some of the root causes are and how we can work together to improve EMS in the state. So turn it back over to you, John.
Thanks, Marty. And so just some of you don't know, Aaron and I, we've been working for a number of years throughout the United States and been working in states from coast to coast and have been very interested in learning about this rural EMS issue. And what you'll learn from us, we were really honored when the Rural Health Resource Center asked us to do this guide. But what we have to say right up front is that we're always still learning. We don't have silver bullets. There is no easy answers and solutions. But what we are trying to do is always be learning. And we've done some of the largest studies of rural EMS across the United States. We are just in the process of completing a comprehensive review of EMS in Alaska, and have worked extensively throughout the Great Plains states. What we hoped to do with this guide was to create what we've learned about helping small communities move from a system that they have today that may not be sustainable to something that's sustainable. So the next slide really is kind of the front cover of this guide, and you can find this online and be able to download it as a PDF. But we just wanted to talk a little bit about it. And the next slide really brings us into this whole idea of what's the challenge? What is the challenge that we're facing? And Aaron, I know you're just fresh from working with a bunch of communities throughout the Intermountain states and Great Plains states. So as you see the challenge today, what is it that rural communities are facing? We all know that volunteerism isn't what it used to be, but what's the real challenge?
Yeah, while it's very complex and nuanced, if we really try to distill it down to some of the most basics, it's really how to pay for something that rural communities have received for free, or they perceived they received it for free for the longest period of time, and essentially replacing the volunteer subsidy. And so what we're discovering, Marty and I, for example, were just recently in a community in his state where the local ambulance provider, a husband and wife team, have been providing the service for many, many years, are choosing to retire. And the community is now asking itself, how will we provide this service? And the question being, how will we pay for it? Because we've been able to receive it, or perceived to receive it, from free for the volunteer subsidy that we've gotten all this time. And so as communities are asking that question, how do we pay for it?
So in the next slide, what we see is the fact that on the surface, this challenge is a workforce challenge, that we've had these systems, we've had these small town services that have been created and sustained through donated labor, and that the way in which EMS is reimbursed has not allowed for these small volume services to be able to hire full-time workers. And so and that's what people see on the surface. So the question is, how do we provide this service if we no longer have volunteers, correct? So, but what I hear you saying is underneath is really a deeper issue, which is a deep understanding of how EMS has developed and how it's delivered and how it's funded and how it's really valued in the community. So if that's the issue, Marty, just tell us what you're seeing from a very practical standpoint about services in South Dakota. I know you have about 120 some services, and 70% of those are exclusively using volunteer labor. Talk about what you're seeing.
Yeah, and like you mentioned, 126 ground services. We see, especially over the last couple of years, we're incredibly proud of the work that our EMS agencies have done. I mean, they've really stepped up to the plate. We all understand the pandemic and what that's brought to us, but these individuals that have a primary job, sometimes a secondary job, and then they work on the ambulance in conjunction with that, just have the added stress above and beyond. We actually saw in the state of reduction in the amount of active workforce. So when we did a poll of all the EMS agencies, they came back and said we have approximately 30% of our workforce has decreased just because of the concern with COVID and bringing that home to our family members, especially those that are sick and have some comorbidities. In conjunction with that, we also saw a 13% decrease in the call volume. So it did work a little bit together for us. But you're absolutely right, John, when you say, identifying some of the root causes within communities and starting to have that conversation is critical. And that's what we've seen in South Dakota over the last decade, is starting to have the conversations that some people don't want to have, because it is sometimes uncomfortable when you have to look at the cost and how much communities have appreciated over the years with free labor subsidies. So, part of the work that we do, like you mentioned, is getting out, visiting with those communities, those leaders, getting a better understanding of where they're coming from, how they look at this through their lens, to be able to work together so that we can, get everybody in line and then go towards a common purpose.
And John, if I could, I might add some I like to call kind of big assumptions that has helped to frame our work from our experiences since the early 2000s as this document was crafted. And one of which was the likelihood of the federal government stepping in, sweeping in, and fully funding EMS across our nation is likely not going to happen. Second, the likelihood of our states being able to similarly sweep in, maybe regionalize EMS in our state, and then begin to fully fund it. We don't see any evidence of that happening. Just prior to this call was speaking to some colleagues in Wyoming. I have an opportunity to speak with their governor's council next week about very similar. And so again, same message. The likelihood that Wyoming will have the necessary funds to fully fund EMS across the state isn't there. So what's really informed our work over and over again when we have seen improbable successes, small, rural, remote ambulance services that are thriving, that shouldn't be, based on the normal analytics of a small call volume, higher expenses. Why? And what we find is that a community, however we define community, has chosen to make this, dare I say, an essential service. And so I wanted to just lay that foundation, those big assumptions that really formed this narrative and this document for how communities might have conversations.
Yeah, so I'm glad you did it. On the next slide, what we really talk about is that this work is about working with the rural communities. And I love what Aaron just said, because I think, and Marty, I'm sure you will agree with this, that one of the most important things for us to begin to understand is that rural EMS, largely across the United States today, is a local function. It's something that exists because there's initiative locally. It exists because local people want it and they will support it. And whether that is through volunteerism, or that is through taxation, or that is through some other means of funding, that EMS is a local function. And I think that this is so important to understand, especially during these times of the pandemic, when people are concerned about things being mandated at levels way above their community. And one of the things that we see emerging out of this is a fierce passion to keep EMS local. And so what Aaron and I have learned as we've worked with communities is in recognizing the localness of EMS allows us to begin to realize that the big challenge when we're working with rural communities is really an understanding and an education challenge. It's helping the community to really understand what they have, how it works, what is sustainable, what's not sustainable, and then be able to make decisions from that place. So on the next slide, we really talk about what we've learned in broad brushstrokes, that in many communities, the current model is not sustainable, and yet nothing will change. So not sustainable, let's talk about that for just a minute. When we talk about something being not sustainable, what we are typically referring to is that there are not enough workers for this service to continue to exist at some point in the near future. That may be 5 months, it may be 5 years, it may be sometime in the next decade, but they are not recruiting and replacing people that are leaving with enough people to continue to ensure that there's an equal carrying of the workload. The other piece of this, of course, is also the sustainability relates to the funding as well, which is how is the service actually funded? So Aaron, about sustainability, anything you would like to add to that?
Well, certainly we've talked about sustainability from the workforce perspective, but also an important concept with sustainability, and it's often part of our initial conversations with communities, is this question about what do you want? What quality or quantity? So do you want an EMS in your community? Of course, the answer is almost always yes. What quality or quantity? Best we can get, highest level of service. But then that last part comes to what are you willing to pay for? And what I mean by that is EMS, to also be sustainable now into the future, has to not only be systemized, but also has to be run more like a business. We really have to have a clear understanding of revenues and expenses and Medicare compliance and wage and hour and payroll taxes and supplies and vehicles and depreciation. And so under our club model, where we had a simple checkbook and we had some money that went in and some money that went out, it's asking this new really business acumen from those, and especially in the most rural and remote areas, where we'll have high expenses and low revenues because of call volume primarily. And then, of course, the other thing that we're learning, and it really is emphasized in the document, is the criticality of leadership. We, in our experience in Alaska, as we spent, each of us, John and I, along with Megan, our director of research, spent 2 weeks traveling parts of Alaska, and a wonderful leader characterized it as the criticality of a spark plug. An individual in a community that's willing to be the spark, that starts the fire, and then that fire grows because that spark plug keeps firing. And so leadership, the importance of developing and strengthening leaders who can use a document like this and have a conversation, can transition from a club model to a business model, can lead this bridge over the dangerous waters of what we've always done historically to what we might need to do into the future. And so being more like a business, and also the criticality of the leader, of that spark plug, beyond just the person who orders supplies, gets the truck maintained, and manages the schedule. Really, truly can inspire people, can see a destination, inspire people to follow, and get stuff done.
So if we need that kind of energy, Marty, I'm just curious, what are the clues to you that a service, how does a service usually approach you when it's not being sustainable and reliable? What we mean by reliable is it's not able to hit its calls all the time. What do you usually hear, and what is their request to you? What are you typically hearing?
Yeah, so we look at it, and you may have referred to this before too, is we look at shoe time as a measurement of the health of that ambulance, just as one small aspect. It's not the bread and butter by any means, but when we have ambulance services that call us up and just say, hey, we're missing calls, and it's not a nursing home transfer, it's not an interfacility, it's a cardiac arrest, a major trauma. And those are the type of calls that people typically come out of the woodwork. And when they call us up, a lot of times, as you mentioned before, it revolves around just a lack of staffing. Some of our communities are more bedroom communities where the individual, people are going out of town to do their primary job during the day. Leadership is a big one. We had a small community here that was really struggling to make those calls that I just mentioned, and they had a change of leadership, and it took probably 6 to 9 months, but now that service has a roster well over 20 active people, and they're thriving. They're making some change. But like you mentioned, having that positive leadership, it really encourages people and brings people to the forefront to say, I want to be a part of this organization. But yeah, you're absolutely right. A lot of it comes down to that workforce. It comes down to personal challenges that these individuals have, being able to dedicate the time to being on call, things of that nature. Does that help, John?
Yeah, that's perfect. So one thing I wanted to just chat for a moment about is that often in our work, so when a service shows up and is struggling to have enough people, one of the first things that everybody wants to do is fix volunteerism. So in other words, what they want is tell us how to recruit and retain more people. In our work, Aaron, we're finding largely that volunteerism is in many communities not going to be sustainable. Talk a little bit about why trying to fix volunteerism doesn't work.
Yeah, and often this can become, as you could imagine, a difficult conversation, because what this conversation about volunteerism being sustainable is not about is the dedication, the pride, the ownership, the sacrifice that the men and women across our nation in our most rural and remote areas have made. And I know those listening today know this, but I'm going to be very overt about it. These are the men and women who have given literally their lives to this thing called emergency medical services. Birthdays, holidays, vacations, significant moments in their children's life, because when that pager goes off, they'll drop everything and go. I could tell you stories about the one EMT that a service in Wyoming has left, and that person, along with the driver, still continues to go on calls no matter what. The person who came to one of our courses would have been on call 243 days in a row, and the only reason why this person wasn't on call is because they were at our course in a different community. But what we know to be true in healthcare in America is that things have changed. We are no longer a transportation service. Healthcare now is in the back of our ambulances. 12-lead EKG, some type of CPR assist device, many ambulances now having Wi-Fi in them to be able to collect and transmit data. We know that our education for emergency medical services personnel has really transitioned from what to do, more skills-based, to why to do it, more anatomy and physiology and disease processes. We know healthcare is now systems of care, STEMI, stroke, sudden cardiac arrest, trauma, and now sepsis in many cases. We know that our rural communities, those hospitals that historically we took everybody to, and you were often birthed there, you were treated for the first things when you broke the first bone and this, that, and the other thing, and respectfully, you died at that facility. And we know that's not true anymore. We know those facilities provide basic care and stabilization as well as general practice care, but then they're often transferring those patients to that next level of care. So all of these have come together along with our nation's change in volunteerism, the change in the social economics of rural communities, that perfect storm. I often characterize it as the tsunami, the silent tsunami, has hit us. And if there was any positivity with COVID, so I say that very carefully, so please hear this in the light that I'm intending it. It's shined a light onto this workforce challenge with EMS across our nation, as all of this was already happening. And now, in light with the Great Resignation, we're seeing what has been there for some time. We're seeing it now with eyes wide open. And I don't think any of us would perceive that systems of care are going to go away, that our small, rural, critical access hospitals will somehow become level 1 trauma centers, that will change how our communities, our nation sees volunteers and volunteerism. Those are now our fabric. And so what the challenges in front of us is, do we keep trying to solve the challenges that are facing us with the same thinking that created them, to steal from Einstein, or another Einstein quote, which is doing the same thing over and over again, but expecting different results? And was so pleased, excited, and proud of Nicole and her team to really craft the concept of this document, which was to say, might we create a guide to help those at the local level really navigate this change? Is it, to the best of our ability, could we create a step-by-step process for something so complex, nuanced, emotional, personal as a local community's decision about emergency medical services?
So I in creating this document, to build on what you're just saying, we wanted to share some things that we've learned. When a community can no longer throw Band-Aids and duct tape and bubble gum and baling twine on its current volunteer system, and it must change, how do we begin to lead that change? So when there's a recognition that the current model is not sustainable, that's the first step. And we've learned that as long as you want to fix the current model, that it's very difficult to navigate change. But once you do, once you're convinced that the current model is not sustainable, the next step that we've learned is to create a sense of urgency. That sense of urgency leads to creating a group of people, what we call a committed coalition, who will then really begin to understand the situation and the full cost of providing EMS. That leads to an exploration of models, a choosing of a model, developing the funding that will support it, and then the implementation of that model. But here's what we have to say. This process doesn't happen in 3 months or 6 months. This is a multi-year process. And we wanted to present that in this document. So if you go to the next slide, you'll see that we've laid out this document in 6 steps. The first step is that of forming an EMS working group. The second one is assessing the situation, then sharing those findings with the community, exploring the various models, getting support for that, and then implementing the change. Each of these steps are critically important in navigating this change. So I want to back up just a second, and I'm going to ask Aaron to talk a little bit about creating the sense of urgency. Why is that so important, and how does that connect to really, before you can even begin this 6-step process, there has to be a sense of urgency? Talk about that.
Yeah, and there are many folks much smarter than I that talk about this when we talk about just change as a whole. Cotter is a wonderful author, and in one of his many books talks about this as one of the very first steps, is creating urgency. And it really just pertains to us as humans. So when EMS feels out of sight, out of mind, when we personally haven't used it and maybe don't think that we'll use it in the future, someone coming in and saying, we have to do something different. And that something different likely will cost us money, and likely will mean that each of us will have to make some sacrifice. And maybe that's about dollars that we contribute or the price we pay when we use it or something. It just falls on deaf ears. Something else has our attention more. And so because EMS is also so personal, especially to those that do it, it is how we define ourselves. This is my 33rd year as being a paramedic. And I still, when asked to introduce myself, will simply say, hey, I'm a paramedic, as compared to many other things I could use to introduce myself. It becomes very personal. So urgency, and I might even add in urgency that is based on data, facts, because otherwise it becomes very emotional. When I say, hey, I'm this community person that feels like EMS in our community is not sustainable. I notice that often there's nobody on call. I've seen some times when the ambulance has been delayed. I heard about times when it's missed calls. I think we need to do something different. That can be perceived, of course, in all kinds of negative ways. You could think of Kubler-Ross's 5 stages of grief, and John actually often adds one more stage in front of all of them, and the first one is shock. So it's kind of thing. And so this urgency is one where we all collectively agree that the path forward will require us to do something different. And now we can align around that versus what the noise might be on the different parts.
And what we often find is that, of course, that the urgency isn't there. There is a desire to do something or rekindle the roster and bolster that, but not a sense of urgency for change. So, but when that urgency does come up, people will often ask us, what should we do first? And the first step that we have found is really, really key. So since EMS is local, and that it's going to need support far beyond the group of men and women who are the EMTs, the drivers, the paramedics in that service. It's going to need broad community support. So the first step is to create, to use what Aaron was talking about, Cotter's next step is to form a powerful coalition. And that's to form an EMS working group. And in the guide, we talk about how to do that. We talk about what the charter of that group should be and who the members of that group should be. Those people should represent a broad cross-section of the community and include leadership people in that group, because decisions are going to need to be made that are far beyond the clinical care and operational concerns of running an ambulance service. So forming that EMS working group that has perhaps business people, has community leaders, has professional people in the community to begin to start discussing this fact that we're not sustainable. The second step along that path is to really dig in deep and assess the current situation. And if you flip to the next slide, this assessment is a in-depth look at what's going on. And the things that we will typically look at are these. The need for the ambulance service. Why do you need an ambulance service in this town? What is the real need for that? We'll look at the structure of the organization as it exists today. We want to know, is the service reliable and sustainable, and for how long? Is it missing calls, as Marty suggested? Is it unable to get out the door time in a reasonable amount of time? Then that assessment will also calculate and tabulate the full cost of service today. What is the value in real dollars of this service today? So the vast majority of cost involved in EMS is labor costs. In rural communities that use donated labor, this cost is not accounted for. And so coming to a point where we finally begin to account for that is fundamental. And then there's this looking at what the regional resources are, what are the possibilities, what are the models that might work within that region, and then summarizing these findings in terms of what is it that we have today. The assessment, this step 2, is really this entire look at what the service is doing. So Marty, often this is what you ask us to come in and do, is to help do this. But talk about how services need this information before they can even begin to think about what to do next.
All right, there. Yeah, I mean, so it's absolutely key from a local level for the community to embrace this concept like has been talked about. Everybody needs to come around the table and to be able to truly understand where they are in the situation, and then all these factors, so that they can start pulling a variety of things together. You know, what is the annual call volume for this particular service? How far is it for the next, until the next ambulance service could potentially get there as a backup? What other services can that ambulance service provide in that community, above and beyond a 911 response? So there's a lot of different factors involved with that. A lot of it comes down to, having that ambulance director and that ambulance crew understand where they are. And that may sound kind of funny at times, but if I'm on an ambulance service, I may be appointed the director, and it's a learning process right from the start. So part of this is just having people realize where they are and kind of giving them a starting point of where they need to go next in the full process. So getting all this stuff ready to go right from the start, it expedites the overall process that much more, so that factual information can be brought to the larger group, and they can start having those conversations that are meaningful and get the process moving.
Right. So this is the information gathering stage.
And John, if I might add, this work often is about maximizing what's already in place. I'm not sure that we've done one single assessment, and others do this work as well, where we've ever found that the business side has been maximized. Often rates, for example, ambulance services not billing at all, billing below Medicare allowables, setting rates at Medicare allowables, rather than the difference between private insurances and such, and all of those pieces. But that won't close the gap. This work won't go from, oh my goodness, we just tweak our rates, all of a sudden now we have enough money to have a full-time service. But first and foremost is that analytical, that quantitative. But we really encourage this work is also really qualitative, because that's really going to be the defining principle at the end of the day. Community, do you want EMS? What are you willing to pay for? So it's really about gauging the community's interest, desire, connection to emergency medical service, image and reputation, the standing within the community, the connection with the business leaders, the Chamber of Commerce's, the influential community members who may indeed have nothing to do with EMS, but yet when it comes to a decision in town, everybody says, oh, got to go talk to Sue. Sue's the one that gets the money for the library and that thing we needed at the school and that new playground equipment. So it needs to have equal parts of a business kind of thing, but also this more organic piece that says, if we want it, we will fight for it.
So going back to the previous slide, the one that has the steps on it, notice that what Aaron is talking about is taking us to step 3. Once you really understand the service and its current situation, step 3 is really sharing that with the community. And what we typically find is this is where there is often sticker shock. Sticker shock that says, oh my gosh, if we had to pay for this service, this is what it would cost. And this is where we are today. And this is how long we might be able to sustain this. Sharing the findings with the community is an important and vital step. If you do not have broad community understanding, you won't get broad community support. So often we find as we do this work that when we share this with the community, there is a period in which it takes time for people to absorb this information. They are not ready to talk about change yet. They're simply embracing the fact that what they've enjoyed for 40 or 50 years is not going to be sustainable. And this community meeting discussion often will go on for months. And there may even be a year or more lapse in between when you really assess the current situation, present the full value and costs of providing EMS, and sharing that with the community before people are ready to take action. But when they are, that takes us to the 4th, 5th, and 6th steps, which is to explore the various models and then get support for that change process and implement the change. So these steps follow from that. But and what I just want to say is, if you don't do the first 3 steps right, and what we see is people want to jump to 4, 5, and 6 really quickly. And what we've learned in our work is that 1, 2, and 3 are where you have to invest the time, energy, and effort. Marty, Aaron, any comments on that?
And Marty, please add this example where Marty and I were just recently. The local ambulance provider was receiving a community subsidy of around maybe $50,000, $60,000. But unknown to most was that the owners of this organization put in time every day, 24 hours a day, 365 days a year. So as we ran the numbers and showed them the gap between what they could reasonably get in fee-for-service revenue and what would be required of what would the need would be for EMS in that community, the gap was around $800,000. Stunned silence. And of course, I naively, being the guy who wants to check stuff off the list and get things going, was ready to facilitate a conversation with county commissioners, city council members, community leaders about what comes next. What were they ready to do to roll up their sleeves? They weren't ready yet. They needed to absorb, to simply grasp how something they thought was expensive at $50,000 in subsidy was going to cost them 800 some thousand in subsidy. They needed to get through those steps as well. So I don't know, Marty, if you had that same observation, not only from that work, but similar.
Yeah, absolutely. And I often wonder if be able to capture that information and have them share that with other communities before they get in the same situation. The community you're mentioning, they gave well over a year's notice, almost 2 years notice in preparation. However, there's other communities that give us only 30 days to say that our ambulance service is going to close. So it is vital to have those conversations, find out where your ambulance services are so you can start preparing those for what's to come.
You're muted, Aaron.
I might also mention under the Explore alternate models, we certainly can think of many, which is some full-time staff, some part-time staff, community paramedicine, community EMT, partnership with healthcare facilities. But one that often has a strong emotional response is any type of system conversation, where maybe a group of them. So there's an area we worked with in Wyoming, that's similar in Nebraska, where in one county within 10, 15 miles of each other are 4 different ambulance services. Understandably, small communities may be doing a few hundred calls, if that, a year, all struggling on the same things, finding resources from some of the same tax base, finding and keeping people from the same group of people, all of those things necessary to operate an EMS organization in 2021, 2022. So one possible model in thinking about alternative models is some type of collaboration, some type of system approach. And as I think this group would well know, that can be strongly emotional. I kid you not, and I know this group will know it. We suggested that in a particular case in a particular state, and the issue was the town next door took the county seat from them back in literally 1800 something. And so, I mean, those feelings run deep. Whose name will be on the truck? What color will it be? We have our set of officers. What about their set of officers? How will we reconcile those? But this time when every community organically had EMS, it was easy, relatively speaking, to become an EMS practitioner. Horizontal transportation was easy to find and keep. Our operating costs were low. Volunteers were everywhere. Doesn't exist anymore. And so we'll likely have to look at models that have collaboration. And it might be just on training, it might be on oversight, it might be on medical guidelines, and it might be in system of how we develop and deploy the resources. But that can be one of the most tender subjects. And going back to why this work group is so important is then that community can hold that emotion and can help all of them through that in a way that some folks from the next town over, right? What's a consultant? Anybody who lives 30 miles or more away can have.
Yeah, so I love that you talked about it in the sense that there is an art to navigating change in rural communities. Everyone would agree that change in rural communities doesn't happen fast, and that you have to accommodate not just the numbers and the business strategies and the models, but also the feelings of the people. And what we found is each community is unique. This guide, these 6 steps, are simply a way of presenting what we've learned, but each community will approach it differently. And if you can go to the next slide and then the next one, that one right there, the one with the guide. Up one more. There we go. So this guide, you can just download it from the Rural Health Resource Center. Just Google Sustainable Rural EMS Navigating Change. You can get the PDF. I encourage you to read it, share it with other people, and use it as you're approaching these changes and working with rural communities. What we're happy to report is that it works. We're seeing all over, we're seeing communities begin to wake up. And even though the process may take a number of years, people are beginning to start really recognizing the value and importance of rural EMS. And rather than it just be a small roster of people keeping this sustainable, it becomes the whole community doing it. So thank you, guys. I'm going to turn it over back to Nicole and let her take over for the remainder of our time.
Great discussion, you guys, and I'm sure people have questions, and I'll open it up to questions in just one second. I just want to talk really quick about how flex programs can support what we've been talking about here. So there's lots of options for what a flex program can do to support addressing the needs of rural EMS in their state. Broadly, as long as an initiative meets the goals of the flex program and falls within the activity categories of EMS, or, again, broadly speaking, operational and financial improvement, whatever it is, a flex program can choose to focus on it. But for rural EMS improvement, that program area specifically, the first thing is statewide and or community level EMS assessments to inform action planning. So helping to identify who the communities and ambulance services are and how they're doing. Do they have an EMS problem, as we've heard described here today? So the recommendation of flex programs is partner with your state office of EMS folks. Find out what they're already doing and what they already know, and how your flex program can work with them. The other activity categories for that program area are EMS operational improvement and quality improvement. So providing the training and tools ambulance services need to become more sustainable. The other thing I would say, flex programs can and have supported the process of convening stakeholders to discuss issues and how to address them. Flex funds can be used to bring healthcare and community stakeholders together to discuss options, interests, and feasibility in different solutions. So those are the couple of things I wanted to say about ways that flex programs can support this. And I think South Dakota Flex has been involved to some extent with the work that Marty has been doing. So Michelle Hoffman could talk a little bit about that if you guys were interested in hearing what her involvement has been. But otherwise, I really just want to leave the last couple of minutes for questions. I saw there was a question in the chat from Katie Holstein. It looks like Karen Pearson from the Flex monitoring team placed a link, but also too with the guide that you've received links to, there are templates and different. Can you talk a little bit about that stuff, John? The kind of the templates and really the good meaty stuff that is included in this guide as well.
Yes, we tried to really include some practical things, everything from how do you create a charter for a working group? How do you conduct that first meeting? What are the things that you should be doing in terms of the assessment? How do you sort of put those pieces together, and what questions should you be asking? So all throughout the guide are very practical applications. And again, there isn't a law or rule that says you have to do it this way. These are just the things that we continue to learn. And in the midst of doing it, we're always willing and ready to answer questions and provide feedback. So what we've tried to do is keep it short enough that it's usable, but provide the kind of materials that will help you through each step.
We like to think of meaningful, measurable, actionable. That you could pick this thing up, or anyone could pick it up and say, gosh, I could use this resource and facilitate that meeting, or take that next step, or know what comes after this.
Yeah, absolutely. All right, anybody have any questions? Feel free to unmute your mic and speak your question, or put it into the chat if you'd prefer.
Hey guys, I have a quick question. This is John from Wisconsin. Have you guys ever done any comparison to other kind of essential service, not quote unquote essential services, but like garbage collection in a community? So I hear the 800,000 number, and I think it would be valuable in that kind of stages of grief and acceptance for a community to start to get, just say a ballpark, like, hey, just out of the gate, we're probably going to be talking about $1 million a year or something. You know what I mean? Yeah. Like, yep. We'll have to dig into it, and it might be different, but ballpark, we're thinking, have you ever done any comparison to say, garbage collection in your community, probably about X, or, school buses or whatever, just to sort of pitch it? Because one of the things we always say in our conversations is, we know this is a lot of money, and yet small communities have figured out how to do this all over. Like, we should ask how the volunteer cops services do it. And then they'll pause and they're like, wait, what volunteer cops? Exactly. So we can afford services if we value them as a community. And garbage collection, when was the last time you had a volunteer garbage collector? So, so just to compare that side by side, make it tangible in that way. So I see you smiling here. It sounds like maybe you've done this, so love to hear it.
The one we often use, certainly you'll relate to it, as our lesser state to the east of us. I have to give you that after the Packers have not treated the Vikings very well lately. But snow plowing, right? So let's think about snow plowing. Snow plowing budget is often about $500,000 a year. And a vehicle costs somewhere between 200 to 500 some thousand, depending on, big one, little one, county truck versus city truck. And so one of the things we often do, and you'll enjoy this, is we'll come into a community and we'll say, Mr. Mayor, John, thank you very much for having us here today, and council members. And you notice in front of all of you is your budgets. So if you wouldn't mind, please go to page 6. And okay, so page 6, about halfway down, do you see that line item for about $500,000? Oh, yeah, we do. Good. We just want to let you know we've figured out how to fully fund your ambulance service going forward. Oh, thank you so much. That 500,000 you see for snow plowing, what we'd like you to do is move that to the ambulance service and make snow plowing volunteer. And they often smile, but it begins a conversation, as you're saying so well, which is to say, so in a community, we've decided something like snow plowing, trash collection, maybe our street department, our park, or whatever we've said is essential, using that word. And so it gives them a chance to start doing that comparison. So broadly speaking, a basic life support ambulance with 2 full-time personnel, 24 hours a day, is going to cost $500,000 and is going to need, if it was solely funded from fee for transport, 650 transports a year. An advanced life support ambulance is going to cost you somewhere between $750,000 to $1.2 million. And is going to need about 1,200 to 2,000 transports a year to be fully funded. And I can walk anyone through that math really quickly. It uses data from the Bureau of Labor Statistics and a non-for-profit organization called the Volunteer Sector. But as John was alluding to, a way to connect that narrative is with something that they would define as essential. We would not have snow plowing. We wouldn't allow it to be something where if John Becknell feels like getting the plow truck out today, great, but not so much because maybe there's something good on TV. We say it has to happen, and it has to happen all the time. So that's the one we often use and is benchmarked with very similar expenditures from a capital and operating is snow plowing. And I'm sorry for those from Florida or elsewhere. I'll find you one.
Yeah, I love that. That's a great one. I think another thing, by the way, I can see why you all would feel bad with having only 10,000 lakes over there. But anyway, so it's lake envy. That's all it is. But anyway, another thing we'll do is try and divide it out by the county resident, because if you really get that, if you get it per capita, and you say to folks okay, that's $50 a year. So is it worth $50 a year to have 2 highly trained professionals show up at your house or roadside to save the life of your loved one? $50. How much is Netflix? Because I think a lot of times folks don't realize that they're not already paying for it. Because if you talk to the commissioners and the et cetera, they know where their budget's coming from. But a lot of the public doesn't. They assume that it's a paid service. And when it's not, that's sometimes something of a wedge. But I love the snow plowing one. Thank you for that.
Great. Anybody else have questions for our speakers today? I do see there's one in the chat. Will Moran from Vermont, and I apologize if I pronounced your name wrong. From your experience when communities have failed to transition from a local volunteer service to a sustainable EMS system, what were the common barriers that derailed change? Is it local cost, local control?
Yeah, certainly Marty and John, please jump in. A couple of things come to mind. Often cost is one of them. But often one of the others is a lack of recognition that there is a problem. So let's imagine you're a community that does 100 calls a year. It's 1 call every 3 days, roughly. And maybe that call doesn't take more than an hour or so. It'd be really easy to not know that a majority of the time you don't have emergency medical services because they haven't gotten the call. Right? They might use what we often call a cattle call, which is when there's a page, when there's a need, the page goes out. We see if between Marty, Nicole, and Aaron and John, if one of the 2 of the 3, 4 of us could go. So we don't really know. We don't have the data, nor do we know how long it took the ambulance to get there if they've missed calls. And the other thing is it can also be those of us that are doing the EMS, because a change to maybe a part-time model or full-time model may mean that I can't do it anymore. And as a person who grew up as a volunteer out in a town in the middle of Minnesota, in Wilmer, Minnesota, I can think easily back to those days and remember how I felt when the ambulance service started talking about going full-time and bringing in paramedics. And I had to ask myself, do I either want to continue my career in computer science and programming, or do I want to become a paramedic? Because I couldn't do it, as my words, in more of this hobby, something I did in addition to other things. And so then I can feel really, really hurt by that when I don't get to be part of the future. So Marty, what do you think? I mean, this is, again, something you do every single day.
Yeah, it's tough. You know, what I see in the communities, I mean, it's, and I say this over and over during this webinar, but it's getting to know those individuals that are putting in the time, that are working the streets, and appreciating from their perspective what's going on, not only in their business, but really personally, and how they're interacting and how they're trying to sustain an ambulance. And it's interesting when you go to some of these communities, is they're doing everything they can to hold it together, and oftentimes it's one person that is giving their blood, sweat, and tears for it. And coming in from an outside perspective, it's like you can see the writing on the wall, and you can see that you know, the service isn't going to be sustainable just walking through that conversation, helping plant those seeds to help them transition a little bit more. It's tough sometimes having those conversations, but it's very, very vital.
Great, thanks. We are absolutely out of time. We're even a couple minutes over. Obviously, we could keep talking about this because it's a big subject and a really important one. So this webinar is being recorded, so the playback will be made available to our Flex programs and State Office of Rural Health contacts, and through the JC Rec, and we'll find all kinds of ways to get this playback out there. Once the playback is available, absolutely share it around, share it with anybody that needs to hear this information. And Kiona popped up some polling questions there. So on your way out, before you leave, before you click the X, if you wouldn't mind answering just those last 4 polling questions, we would really appreciate that. So with that, thank you everybody for joining us today. Thank you, Aaron. Thank you, John. Thank you, Marty.